Good afternoon, everyone. My name is Alicia Smith, and I have the pleasure today to be joined by my colleague, Erica Haller-Stevenson at NACCHO, who is going to be our co-host for this webinar. I work with ASTO, the Association of State and Territorial Health Officials, where I'm the Director of Chronic Disease Prevention, and I'm very excited and looking forward to the rich information that's going to be shared today on the webinar, Best Practices and Engaging Health Officials in Tobacco Control and Prevention. Erica, would you like to introduce yourself to everyone?
Yes, my name is Erica Haller-Stevenson. I work at NACCHO, the National Association of County and City Health Officials, and I also focus on tobacco and chronic disease prevention. We welcome you to today's interactive webinar.
Great. So, this is our agenda for today's webinar. We got some very great information that we're looking forward to sharing with you all today. And so first up, we have ASTO's 2016 President's Challenge on advancing health equity and optimal health for all. This is really designed to promote the objectives and the triple aim of health equity, which is to expand our understanding of what creates health, taking a health in all policies approach with health equity as the goal, and then strengthening communities' capacity to create their own healthy future. And you'll hear more about our President's Challenge in today's webinar. ASTO is a national nonprofit organization representing public health agencies in the United States and the U.S. territories, and also the District of Columbia, and over 100,000 public health professionals that these agencies employ. And so ASTO members, the chief health officials of these jurisdictions, formulate and influence sound public health policy, and they also ensure excellence in state-based public health practice. ASTO's primary function is to track, evaluate, advise members on the impact and formation of public or private health policy, which may affect them, and to provide them with guidance and technical assistance on improving the nation's health. Here's some logistics for you to be aware of if you have trouble hearing us through your computer screen. There is a phone number there, and please remember to mute your line. Without further ado, we would like to introduce our speaker today. We're joined by Dr. Edward Ellinger, who is ASTO's President and Minnesota Commissioner of Health. As so eloquently suggested, Dr. Ellinger has shared that our thinking about health, policymaking, and the capacity of local communities must change if we are to address the wide health disparities in our state. The Minnesota Department of Health's 2014 White Paper on Income and Health documents the impact of economic conditions on the health of Minnesotans, particularly populations of color and American Indians, and the authors of the White Paper note that being at the bottom of the economic ladder leads to an average decrease in life expectancy of 8.4 years and nearly a 10-fold increase in poor or fair health days. We are very pleased to introduce Dr. Ellinger and his President's Challenge to share his strategies to address conditions that support improvements to health. Dr. Ellinger, I'll turn it over to you.
Great. Thanks, Alicia, and good afternoon, everyone. Actually, this is a nice day to have this conversation because just this morning my governor announced that in his budget he is going to be asking that paid maternity and paternity leave be granted to all state employees because that was one of the things that we had suggested in a white paper that we did on paid leave in health, that is one of those health conditions or those policies that actually impacts health. We identified the fact that 10 weeks of paid maternity leave can decrease infant mortality by about 10%. So we're excited today that the governor has put it in his budget that he's going to be pushing for paid leave as a health measure in addition to an economic measure and an education measure. It's a health in all policies approach. So it's really good to be with you today to talk about how to engage health officials in tobacco control and prevention. And I will show you how the presidential challenge that I have really fits into that. But I think we'd have to recognize that a lot of people have died because of tobacco use, and this is the anniversary of the death of Sophie Tucker, who died in 1966, and she was a cigarette user. And I was kind to her and didn't put a picture of her smoking tobacco, but she was a smoker, and she died of lung cancer because of that. And she said, "I've been rich and I've been poor, and rich is better." I think we could also say I've been a smoker and a non-smoker is better. We could say I've been ill and I've been healthy, and healthy is better. And that's really what we want to do. We want to get the most out of life. We want to make sure that the conditions and the behaviors that individuals have are born into and live in and choose really are enhancing health, because health is better. So with that, I'm going to talk about, and I'm sorry about this politically incorrect slide on a conference call or webinar that's from both NACCHO and ASTO. It's the role, I said the roles of state health officials. Actually, it's the role of all health officials. And this is what I see as some of the roles that I've identified that health officials, be they at the federal or state or local level, they need to provide a vision for what creates health. That is, I think, one of our goals. And then we have to drive the action to assure the conditions that in which people can be healthy. You can sense that that's from the IOM report of what public health is supposed to be all about. Certainly we have to enhance efforts to prevent disease and injuries, identify barriers to health, in addition to just the basic running of an agency. So I'm going to focus on some of these, but I'm also going to intermix it with the areas where you can engage the health officials. Certainly you can engage them in that mission and practice of public health, because that's really should be, as leaders in public health at the state or local level, really need to be out there talking about what is the mission of public health and what's the practice of public health that really needs to be embraced and used. Certainly building policies from data and experiences, and certainly using partnerships and the bully pulpit that we have to really advance public health whatever the jurisdiction is. And so in that whole role of providing a vision for what creates health, I use the World Health or the Institute of Medicine framework, what we as a society do collectively to assure the conditions in which people can be healthy. And it really springs from how do we get action on changing the living conditions that impact health. And the triple aim of health equity that I'm using as the core of my presidential challenge really hits on those practices that we have to incorporate if we really are going to create health in our communities. We have to start really by expanding our understanding about what creates health, that it's much more than just physical or health care and personal choices. They are important, but they are a small piece. We know that health care is only about 10% of the determinants. Behaviors are about 30%, but even those behaviors are influenced by the socioeconomic conditions in which people live. And so the socioeconomic conditions on most charts is shown as about 40%, but I believe it's really much greater than 50%. Secondly, we have to implement a health in all policies approach with health equity as the goal, recognizing that health is not just the responsibility of the healthcare sector or the public health sector. We need to engage transportation and housing and corrections and education and economic development all in that. But we always have to have health equity as the goal, because without that focus, we can have some unintended consequences. So just for example, as we're talking about paid leave, if only full-time employees in higher paid occupations get paid leave, even though that will enhance their health, if we don't also have paid leave for lower income part-time workers, we'll actually enhance the disparities, because the people who really are lower income and at the lower paid and part-time workers are usually populations of color and American Indians, and certainly low-income populations. So if they don't have that benefit of paid leave, the disparities can actually increase. So that our health in all policies always has to take that health equity framework. And finally, strengthening the capacity of communities to create their own healthy futures. Action actually occurs in communities. It's relationships. It's the social cohesion. It's the relationships that are there. And as you see these things, think about how that really relates to tobacco control. Expand our understanding about what creates health. We know that economic conditions and marketing and education all impact that, our understanding of health, that it is much more than just health care. Health in all policies. We need all groups to really focus on reducing tobacco use. and strengthening community capacity. As you'll see when I talk about partnerships, it's really that community capacity that has really moved things forward in our state, and I think moves things forward in states throughout the country. So when we provide a vision of healthcare, it really is what creates health, and this slide shows the real reasons why dinosaurs became extinct. It's because they started smoking. But health is really not created just by healthcare and personal choices. You have to make sure that I left out just or solely, because healthcare and personal choice are really important. But it really is mostly in communities through policy system and environmental change strategies. So that's when we provide a vision. I think health workers, particularly health leaders at the state and local level, always have to recognize that health cannot exist individually. It has to exist in communities, and communities really have to look at all of the factors that go into health. It is about community development. And certainly, as we pointed out in our Advancing Health Equity report, that not everyone in Minnesota shares equally in all of the benefits of the state. I think this quotation from Alice Walker, whose birthday it is today, she's the author who won a Pulitzer Prize for The Color Purple. She said, people tend to think that life really does progress for everyone eventually, that people progress, but actually only some people progress. I think we really identify that we really have people and populations and groups that have been left behind by all of the advances that we have in our country, and not by fault of their own, but really by the fault and the reasons because of the systems and policies that we put in place. So we always have to think about the equity that goes into this. And certainly when I was talking about areas to engage health officials, it's that mission and practice, and certainly that focus on health equity, and that everyone really needs to be engaged. One of the tools to engage is through data. And certainly this slide shows that we have lots of data sources that we can grapple with and we can tap into in our state. And my guess in all of your states, you have a variety of data sources that you can go to. Certainly here we have the Behavioral Risk Factor Surveillance Survey, the Minnesota Youth and Adult Tobacco Surveys. We have a student survey for all of our students, and then a whole variety of other surveys that get done. The College Health Survey, the Voices of Health through the GLBT community, the tribal health groups are doing their surveys. And I know health officials love data. I certainly love data. It helps us make the points that we want to do. It helps us create the conversation about what creates health. So use the data that you've got. Mine it for everything that you can. Certainly here it just shows the fact that if you're lower income, if you don't have work, if you're unable to work, lower education, if you're African American, an American Indian, you really have your risk of tobacco use increases dramatically. So the data help underscore some of the anecdotal evidence and some of the values that we really want to push forward. So always you think about the data that's there, and engage your health commissioner or your health director with the data, because that's the cachet for public health. We need that. The other is we want to drive collective action. One of the second roles is drive the collection action to assure the conditions in which people can be healthy. And it really helps for me to help the governor to be a public health champion. Just the fact that the governor today in our state was pushing paid leave really helps us build the coalitions about all of the social conditions. The fact that when the governor in our state was pushing for buffer strips in streams and rivers throughout the state in terms of water control and water quality, he led with a health message. The fact that the governor was really opposed to a tobacco tax, but when he recognized, because he thought it was a regressive tax, but when we talked about the fact that tobacco use is a regressive disease, a regressive behavior, he came on board as a health issue. It wasn't as a revenue generator, but a health issue. And that helped us build coalitions and support coalitions. So anything you can do to get your governor or your mayor or your city council members or your county board on board with that health message, remembering that health is an economic driver. It is something that pulls all things together in a community. I always use the quotation from Herophilus of Chalcedon, who was the physician to Alexander the Great. He said, when health is absent, wisdom cannot reveal itself, art cannot become manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. Without health, nothing in our communities really function optimally. So your governor, your legislator, your council members, your mayor, your county commissioners all need to recognize without health, everything else that they do will not be optimal. And that's really nice to bring those leaders in as supporters of public health. And it helps then to really generate the partnerships that need to be there. Certainly the partnerships that we have in Minnesota have actually helped us move the anti-tobacco agenda forward. The health department by itself could not have done it. The local health departments by themselves could not have done it. We needed a broad coalition of groups and agencies. Certainly our Clean Indoor Air Act, our tobacco tax increase, the work that we're doing on menthol, flavored tobaccos, and the work we hope to be doing on minimum legal sales and strong tobacco control have to come from a community effort. That's why one of the parts of my triple aim with health equity is strengthening the capacity of communities to create their own healthy future. A lot of the work that we have been doing related to health equity has been done at the request of communities which have come to the legislature and said, we want the health department to do a report on income and health. We want the health department to do a report on paid leave and health. We want the health department to do a report on incarceration and health. When communities get organized and in coalitions and ask the policymakers to do things, it's much more powerful than when agencies come to their bosses and say, we want to do this. Having the communities there is really important. And certainly just one example of how this works is certainly what we're trying to do with menthol cigarettes. So we're trying to build coalitions, and we can do that through partnerships, but we can also do that through some grants that we give can help enhance those partnerships. And you can see where MDH, the Minnesota Department of Health, really awards grants to local public health, community health boards, as we call them, where they come together in the counties, the local public health. And then those community health boards then partner with community-based organizations, and then they engage the community. It really is a pattern, and we can see we're really targeting African American communities because we see that that's a huge there's a huge disparity in both overall tobacco use, but particularly in menthol flavored tobacco use among the African American community. So this is where you can help build partnerships just by the relationships that you have, but you can also build those partnerships with the financial resources, and together those can really come together to actually move an agenda for public health in our communities. And our partnerships are with the local communities are really quite powerful. We have our local public health grant that goes to all community health departments, but then many of the community health boards have gotten together into other larger groups for our statewide health improvement program, our SHIP program, which really focuses on policy system and environmental change strategies around physical activity, nutrition, and tobacco use. And so we have 41 of those statewide health improvement grants throughout the state. So we cover the whole state with those, focusing on that policy system and environmental change strategy. That partners with the grants that we give to local public health for basic public health services. We also have grants to tribes and to tobacco-free communities. All of that really covers the state, because I do think you need to have a statewide strategy eventually. I mean, it certainly can bubble up from local areas, but once you have a statewide strategy, then it can partner, it can leverage each other, and you can actually move things forward. Particularly for us, it's been really nice to start working with the tribes because of their unique needs and the different approaches that they take. So there are tribal communities are working on their own community initiatives in ways that match their culture and their approaches, and the cultural awareness that goes on in that. So you really have to be aware of that and supportive of that as we move forward. Another partnership that certainly is a really powerful one is the partnership with Medicaid. It's starting this year, January 1st of this year, in Minnesota, tobacco treatment is completely free for medical assistance enrollees or Medicaid enrollees. And we waived all the co-pays starting in 2016, because even a little bit of financial involvement out of pocket really decreases the use. So one of the things that we need to do is make sure everybody's aware of this, and particularly to the beneficiaries as well as to the providers. And so we'll be conducting campaigns encouraging smokers to talk to their doctor about this, but we need to collaborate with our Department of Human Service and agencies throughout the state. These are the kinds of partnerships that can actually move things forward. You change a policy, particularly here, an economic incentive work with your providers and partnerships, you can actually move the term. So, it really says, we need a lot of momentum at the local level, we need partnerships, and we need that collective impact. That is how things got done in this state, and my guess in most of your states. If you have something done at the local level and another city or local community does the same thing, and you reach a critical mass, that actually helps change state policies. So I always talk about the fact that we have a public health enterprise. We have federal, state, and local. All three have to be really powerful and engaged and collaborative. We can't do it with just federal intervention. We can't do it with just state intervention. We can't do it with just local intervention. We all have a different role to play, and the public health leaders at all those levels really need to know how to leverage each other, collaborate with each other, work with each other to move our agenda. And so one of the other things that state and local health leaders do, they have to find ways to address those conditions, and certainly policies are really important. And certainly in our state, when we passed the 2013 tobacco tax, where we really worked with our partners to move that forward, a lot of community engagement with that, I argue that this is when we got a $1.80 increase in our tobacco tax, that along with the minimum wage were the two largest public health achievements of the administration that I'm part of. This is really where we really want to push the policy things. And it all built upon a lot of work at the local, from local ordinances, and certainly as part of our health equity agenda. We make equity the centerpiece of everything that we do, because we have some huge disparities. We may be a healthy state in Minnesota, but not everyone. I always say Minnesota, where the women are strong, the men are good looking, and all our health statistics are above average, riffing off of Garrison Keillor. All of our health statistics are above average unless you're a person of color or an American Indian, and then we have some huge disparities. So we lead with equity in all of our policy discussions, and that really helps to target some of the policy changes that need to be made, because people really want fairness in our state. They really want everybody to be healthy, and they recognize that there are huge disparities, and a tobacco tax increase in particular was one that could actually help reduce those disparities. We also do a lot of work with our, to enhance and prevent diseases and injury. Certainly the data collection pieces, the policy system and environmental change strategies, all really work together to data to lead to policy system and environmental change. And you can see some of the policy system and environmental change strategies that we do to prevent disease: smoke-free air in cars, foster care, indoor-outdoor spaces, raising the price of tobacco, dealing with couponing, sampling, marketing, and certainly I think raising the age of tobacco. I really appreciate the states and localities that have really moved to make tobacco sales under age 21 illegal. That's going to be a huge benefit as we move forward, because the IOM report that came out on that really pointed out the benefits are tremendous, and we can really have a huge impact on that. And we can certainly start at the local level and the state level to make that make that work. The other thing that health officials have to do, they have to identify the barriers. And we know that the tobacco industry never stops looking for ways to get people addicted. The marketing campaigns that go on, the e-cigs that have taken off because of our success in many of the other areas of tobacco, they found that e-cigs was a place to actually really try to get that market moving again. Smokeless tobacco and other products. So we always have to be looking at what the tobacco industry is doing. And they're using, some of the same techniques now that for e-cigs that they used 50, 60 years ago. So we have to be thinking about that. We also have one of the barriers that we in public health, particularly governmental public health, is that there is now a feeling that, that the smaller government, the better the government. And we do think that there is a role for government in regulating things that actually impact the health of the public. Our air and the health of our people are a public good, and so there needs to be some oversight that has to happen. So we always have to battle against the fact that, making public health go away will not actually be the healthiest thing for our communities. I mean, just the example going on in Flint, Michigan, where how important it is for government to be involved and government doing it well. We need to make sure that the infrastructure for tobacco control in particular remains strong, and that's why some of the issues that we have with reducing funding for tobacco control we think is short-sighted, because once that tobacco control effort goes away, improvements start to slow down and sometimes even start to rebound and get worse. So I think, in our state where we had the Freedom to Breathe Act, where we expanded our Clean Indoor Air Act to bars and restaurants, we celebrated, but then I think we took our eye off the ball, and we then started to see slowing in the rates of improvement. And so we need to refocus and always keep tobacco as a focus. That's why in my work with ASTO recently, I was on the Tobacco Issues Forum chair and on the Prevention Policy Committee, and always arguing that, yes, we're making progress in tobacco control, but we always have to keep it as a priority because it's still the #1 preventable cause of death in our country. And if we take our eye off the ball, the tobacco industry is always there to fill in the gap. If there's dead air space around an issue, they will fill it up with really enticing things that will entice kids and young adults to take up nicotine. And so I know we get a lot of issue fatigue. What's the latest and greatest thing that we can focus on, and then we do it for a year or two. That's why I think, 2 issues that I work on are issues that I really worked on for my entire life: tobacco use and health equity. These are not issues that are a program, you do the program and you're done. They have to be issues that you focus on continuously. They have to be part of the portfolio of everything that we do. They have to be engaged in all of our programs related to tobacco and equity. And then finally, one of the strategies that you can use to engage your health commissioner or your health director is this bully pulpit. We have certain positions. I'm health commissioner for a limited period of time, but I've got a bully pulpit that I will not have ever again and never had before. So we have to use that opportunity to really help create change. And so one of the ways that we did that here from the State Health Department is we have our health network and health advisories and health warnings. We put out a health advisory on nicotine. It really helped to raise the issue that nicotine for kids, children, and adolescents is really a problem. It damages the developing brain. It's highly addictive. It can also be a poison for infants. So that really helped us to raise the level of conversation within our state. And we partnered with and put out a lot of information related to that throughout our state, an editorial related to how nicotine is really damaging to the developing brain and a problem for young kids. Really raised the level that nicotine by itself is harmful. Because a lot of people thought, well, tobacco use is really harmful, but it's all those other things. Nicotine by itself is really somewhat harmless. Yes, it gets addicted, but it's harmless. We pointed out that it is not that. And also just addiction is not a good thing to have. We don't want any of our children addicted. So that was really helpful. It was a bully pulpit kind of thing. And using this to partner with poison control in our state, which is, again, a really important aspect of our healthcare system, our educational system, our public health system, with press conferences and press releases and information was really important. And then also, try something new, try something innovative. I always argue that if it's not fun, it's not public health. My staff sometimes get angry. No, they don't get angry at me. They kind of cringe when I say that because they say, well, this is really hard work and it's not always fun. I said, well, it's fun in a different way. We are doing important work. We're doing work that needs to be done. We're helping to improve people's lives and enhance their ability to enjoy life. And that's fun, even though it's hard work and we sometimes get disappointment. But also, if you link it with that idea of let's go out and do some positive change in our community, you can have some real joyful fun, the kind that you laugh at. And I've started going around the state several years ago pitching horseshoes with county commissioners who I feel are my real partners in public health. At the local community, county commissioners are really important in advancing public health. So I pitch horseshoes with them and anybody else in the community, and they pitch me ideas about what does it take to create health. And I pitch them ideas about what I see as important in their communities for improving health. And I find that when people don't have to look at you in the eye, when they can look 40 feet away at the stake and throw horseshoes, they can say things that they may not say otherwise. So I've gotten some really good ideas from local communities, but I've also been able to get some ideas to them, and we formed partnerships that have really been helpful as we move tobacco control agendas forward, socioeconomic factors forward in the agenda, the social determinants of health issues forward on our agenda, and public health in general by doing some fun things. That bully pulpit is really important. That's why I also think that the bully pulpit that I have with the ASTO presidency is really important to use whatever I can. And certainly the bully pulpit that we have as health commissioners or health directors is really about changing the conversation about what creates health. That first piece of that triple aim of health equity. The narrative out there is that it's really about medical care and personal choices, and we have to get the narrative out there that it really is about communities coming together to address the social economic factors in those communities, addressing the social determinants of health. And what better place than using the bully pulpit of local public health, of state public health, and federal public health to really make that case. And so we do that in a variety of ways. I do that with Pitch the Commissioner. I do that with writing commentaries to the newspaper. I do that as becoming engaged with ASTO at the national level and working with my partners by advancing the triple aim of health equity, which I think really identifies the practices that we have to put forward in order to be a healthy community, changing our understanding about what creates health, implementing a health in all policies approach with health equity as the goal, and strengthening the capacity of communities to create their own healthy futures. Those three are practices that we have to embrace at all levels within our organizations, change the practice of public health that really focus on health equity, with the center point focusing on cohesion. Health is all about partnerships, it's about social capital, it's about being in relationship. The relationship within communities, relationship between local, state, and federal public health, that is how we're going to move things forward. And so it all springs from this definition that you all know, I hope, really well. Public health is what we as a society do collectively to assure the conditions in which people can be healthy. You know, public health is not about a place of employment, even though governmental public health is really, really important in our overall public health framework. But public health really is an approach, it's a philosophy, it's an approach to life. And this definition doesn't talk about doctors or nurses or hospitals. It certainly doesn't even talk about health departments. It talks about what we as a society do collectively to assure the conditions in which people can be healthy. It focuses on the conditions of what people need, and it focuses on what we as a society need to do. That's why when we broaden our understanding about what creates health, we have more people engaged. We have a broader societal understanding of everybody's role. When we do a health in all policies approach, we recognize that all agencies, all sectors have to be engaged. And when we talk about strengthening community capacity, we recognize that everybody in the community can actually be a public health worker in moving forward on making our communities safe and livable and prosperous. So with that, I'm going to end and open it up to any questions that people might have. Thanks for listening.
Thank you, Dr. Ellinger, for your presentation. Now we'll begin our open Q&A session. If you'd like to ask a question, please type it in the chat box located on your screen, and Alicia will be moderating our questions. Alicia, when you're ready, please go ahead.
Thank you, Erica. So we did receive a question earlier. Are there any CEUs available through the webinar? And there will not be any CEUs offered for the webinar today. We received another question about the content being shared electronically. This webinar is being recorded, and we will also share that recording link along with a PDF of the slides that are shared today on both of our websites. So at the end of the presentation, you'll see our web addresses there, and that's where you could find the recording and the webinar materials. on ASTO and NACCHO's website, and those will be up in about 2 weeks following the presentation today.
All right, Alicia, can I chime in on that?
Sure, go ahead.
Just as we talk about ways to engage the health official in your community, particularly if your health official is a physician, it reminds you CEUs are important. As health commissioner, I don't have many. I need CEUs, I need continuing medical education pieces, and I don't have many opportunities to do that because I don't get to go to conferences like I used to. So anything that you put together where you can have particularly for physicians, a CME, you might be able to get your health official there because he or she could get some CME credits. So it's a tool to get your health official engaged.
That is a great point. Thanks so much for sharing that. We received another question. In order to create a smoke-free generation, would you consider banning smoking sales to anybody born after a certain date, January 1, 2000, for example, so that year after year, the age at which you can purchase tobacco would also increase until eventually no one would be allowed to buy cigarettes?
Well, that would certainly be a good strategy we know that if tobacco was put forward now, it would never have been approved because it is harmful, but it was approved. And efforts to ban tobacco sales totally have not been very successful, but increasing the age certainly is a good way of doing it, and I think is the next step. But I think there needs to be some conversation about, is that an acceptable approach so that eventually we can become a smoke-free generation. I think that is definitely worth floating up as a potential strategy.
Great. We received another question. It would be great if they could get specific aspects of Minnesota's Medicaid Quitline initiative. So are those things shared on your website, or do you have any other tools that you could share with other states?
Yes. So we will have those. I have those on our website. And Christina Thill is from our tobacco control program is in the room here with me, and so she says yes, and we will make sure that they're on our website for people to connect with.
Awesome. Okay, another question. At Americans for Non-Smokers' Rights, they work with many different states, counties, and municipalities that have seen success in smoke-free policy change. However, as a product of that success, there have been threats to preempt local health officials' ability to impact policy change. How could we work together to thwart these efforts by state legislators to preempt county and local official policy change?
Yeah, the tobacco industry really does not like local control because that diffuses they have to then diffuse their efforts throughout the state. So we really want to keep the locals, and that's how a lot of change has occurred in states, is where locals start it and it builds momentum, and then it eventually ends up at the local level. That means, or at the state level, that means you have to work with both your local public officials to say this is a local issue that we have to be in front of, that we need to make sure that we have livable communities, safe communities, and also work with your state legislators who represent those local communities to say, no, like here in Minneapolis or St. Paul or Golden Valley or St. Louis Park or Duluth, say, you need to have, the health of your people is really important and you have a role to play in that. So we want you at the local level to fight any ways to take away local control, and then your state legislators say when you go to the Capitol building in the Capitol, really fight for the local control because that really helps move this forward. It is a collective effort that we have to do.
Thank you.
One other thing related to that is that there are lots of people who have done editorials or op-eds, and I think there are some templates that people could use. Get out that kind of information to your local newspapers. If you start seeing that there's some push to do anti-local control, get out there and get that into the news media in any way you can.
Great. Thank you, everyone. We're getting all of your questions in. Keep them coming. This is a wonderful discussion. Our next question is how did Minnesota accomplish getting the copay waived for Medicaid clients?
Well, we know that, I mean, it's a logical argument. One of the biggest causes of poor health is tobacco use. And we know that people at the lower socioeconomic level, and particularly populations of colored American Indians, use tobacco more than others. We also know that any kind of financial speed bump, economic speed bump, gets in the way of cessation programs. So when we talked with our Medicaid program, they realized, yeah, if we're going to save money in the long run, if we're going to improve health, which is the goal of the Medicaid program, is to improve health, and their administrative goal is to reduce the costs of that program, it was a no-brainer. So you just really need to have a relationship with your Medicaid program, talk to them about how this is going to improve health and reduce costs, and it's going to help reduce disparities. Those are things that I think every Medicaid program, every Medicaid director really wants to do. So it took a while for those conversations to occur, because changing policy is never easy, but it certainly is worth the effort.
Great. Another reminder to everybody, we are going to have copies of the presentation materials available along with the recording on our websites, and we'll show that URL a little later in the presentation. Our next question is asking if it would be okay to utilize or reproduce some of the signage that you showed in your presentation, Dr. Ellinger, for other states to use.
Yes, I'm a public employee, and everything that I put out is for public use. We're a public agency. Anything we produce, we really want people to use it, because we also want to be able to, adopt the stuff that other people use. So we'll share, and we'll use other stuff too.
And is that also available on your website, or should ASTO sort of facilitate how best to maybe get access to that?
You will be able to get it through our website. We'll have some contact information for follow-up, for additional information and resources. We'll have a link there for that.
Wonderful, and we'll get that link out to everyone on the webinar today. Thank you. Another question, what is your advice in building community capacity to advance health equity?
Well, that's a good question, and that is what my Triple Aim of Health Equity is all about. For me, it is getting out there and talking about how do we expand our understanding of what creates health? What really determines health? That is, I think, the first step that you have to do. The general narrative in the country, as I said several times, is that it's all about medical care and personal choices. And when you talk with community groups and you recognize that really housing is really important for health, housing is important for improving third grade reading levels. We know that low birth weight actually impacts a whole variety of factors. And that low birth weight is really not about medical care. It's really about the social conditions in which people live and work. When you have those conversations with people in the community, intuitively they get it, because they recognize in their own mind, when I think about my health, I think about, yes, do I have any diseases or disabilities, but mostly I think about, am I comfortable in my home? Do I have a safe housing? What's in my neighborhood? Can I walk to a grocery store? Can I walk to a restaurant? Is it safe to walk? Is the air I breathe clean? Do I have to worry about the water that I'm drinking? Are the schools good in that? Do I have neighbors that I can interact with? They recognize that their sense of well-being is much beyond clinical care and much beyond their individual choices. It is about the environment in which they live. And once people start to think about that, they start understanding that health is much broader than what they thought about, and that they have a role to play in it. And that's where then they start to recognize that, well, not everybody in our community actually benefits from this, and that when we talk about the fact that in our state, Paul Wellstone was our senator, and he said, when everybody benefits, everybody benefits. When everybody does better, everybody does better. It really reflects the fact that the data are showing that disparities impact everybody in the community, not just those at the bottom. If you look at the national statistics, and this has been really powerful in my conversations, that when the United States started to fall behind other industrialized countries in longevity and improvements in infant mortality, it was the time when our health disparities started to increase. And so our overall health has declined as our health disparities have gone up. When people recognize that even the people at the top of the socioeconomic ladder actually do better when disparities are decreased, it's in everybody's vested interest to do that. So that whole conversation about what creates health, the fact that equity really helps everybody to succeed, that equity is actually an economic driver in our communities, because communities that have lower disparities do better economically. That starts to change the conversation. That then starts to get other people on board with thinking about the policies that they have. So, for example, in our state, I worked with all of the commissioners and other agencies. So when Tom Landwehr, the commissioner of the Department of Natural Resources, thought about health, he says, hey, how about if I open up all of the state parks for free the day after Thanksgiving? That was a health and all policies approach. He targeted that to people who really have difficulty getting to the parks. These are low-income folks and populations of color. Increased the use of the parks the day after Thanksgiving as a health and all policies and a help to advance health equity. It's really amazing that when you have equity, the focus of what you're trying to do, it changes how we do our work, and the work is really that triple aim of health equity.
Great, and we received a compliment of your bully pulpit concept. One of our webinar participants has been doing some visiting and working with elected officials, and it's always been their objective of being able to help them understand public health depends upon officials and communities working together. So you got a bravo in our chat box for that. But our next question is related to if there is a recommended strategy to get health insurers to provide comprehensive tobacco cessation services, i.e. quitline, as an essential health benefit for all eligible covered enrollees.
Mm-hmm. Well, I want to first respond to the kudos, because most people don't recognize how important county commissioners are. Most people don't know what county commissioners do, but they're in our state, and I've lived in 5 other states. In each of those states, the county commissioners were really important in local policies. And if you can get them on board as public health advocates, you have really made a big step forward in advancing public health in your state. So pay attention to those county officials, city council members the same way, and mayors. Really important as good partners that look beyond the traditional ones. I work with local public health agencies. They're great partners of ours, but I also work with the people who they report to, which are the county commissioners. Certainly, we've been working hard on the insurance. All of the things. ACA has really pushed that preventive services should be provided with no co-pays or deductibles. Certainly tobacco cessation should really not have any co-pays or deductibles, and tobacco cessation products that are proven to be effective should be there. That many groups already have eliminated any of those financial barriers. It just needs to be one of the foci of all of our efforts to make sure that all of those barriers are erased, because that's going to be one of the effective ways to move forward.
Great. Next question is sort of wondering your thoughts about having a way to keep people from receiving Medicaid when they smoke because cigarettes are so expensive, and wondering about what your thoughts would be on that type of restriction.
So tell me that again. Keeping people off, threatening not to be on Medicaid if they are smokers? Is that sort of
Correct. So it says it's very good that Medicaid helps people who try to quit smoking. It would be good to have a way to keep people from receiving Medicaid when they smoke because cigarettes are expensive. Any comments or response to that? Yeah,
well, that is one of these things that I don't know very many people who really want to be addicted to tobacco. I think people become addicted to tobacco because of the outside forces that are there. We know the tobacco industry is spending over $1 million an hour, billions of dollars to try to get people addicted, and marketing works. So a lot of people become addicted, not because they're weak-willed, but really because they are kind of tricked or fooled or coerced into this in very subtle but very powerful ways. And this is addiction that is hard to get rid of. So I don't chastise people for being smokers. I don't try to penalize them for being smokers, I say. And I know very few people who really want to continue smoking. They're trying to quit. So anything that we can do to help them quit, and having health care certainly is one of those ways of getting them to quit. A physician or healthcare professional talking to somebody about how to quit smoking, brief motivational interviewing, cessation products are all beneficial ways to do that. So we want to have that link. We want tobacco users who qualify for Medicaid actually to be on Medicaid so that we can actually help them quit, because we don't want them on as tobacco users 5, 10, 15, 20 years down the road.
Yeah, I agree. So we have one final comment and question that came in that talks about many of our local health departments being under the governance of county commissioners, which you've covered in your presentation today. The participant references a case study in which a county commissioner was also a lawyer that represented Reynolds American. The question is, how can a county health department promote public health if their boss is pro-tobacco?
Start with data, and then start with things that you do. So we don't, my governor and I disagree on e-cigarettes or how to regulate e-cigarettes. But we do agree that we don't want adolescents to become addicted, and children and adolescents to become addicted to nicotine. We can agree on that. I think even somebody who's a advocate for and represents the tobacco industry, there are some things that we would agree on. I can't imagine that they would say, oh yeah, we want to addict kids, we want to sell to kids, that we want to market to kids. Start with that, and then certainly start with the data, but also then build the coalitions that that the community can say, we as a community really want to move forward on this, and highlight, when the community can highlight the fact that this person may have a conflict of interest in some of these things, really draws attention to the duplicity of some of the actions that the person might be taking. It's an organizing strategy in that community where that county commissioner may be linked to the tobacco industry. But start with the data, start with the things that you agree upon, and continue to work with community coalitions to change that perception of what's needed in the community.
Great, great. Thanks so much. Very special thanks to you for your wonderful presentation, and thank you so much for responding to all of our participants' questions today. The information, as you know and everyone on the call today knows, is very important, and we're just very grateful for your support to continue to engage our leaders in the tobacco control conversation. And so we really appreciate you joining us today, Dr. Ellinger.
You're welcome. Thanks for the invitation.
Wonderful. So now, before we wrap up for the day, we really want to provide and share some resources from NACCHO and ASSO. So before we close our webinar today, I'm going to turn it back over to Erica so that she could share some of the resources that NACCHO has related to the topics we've discussed today with Dr. Ellinger.
Thank you, Alicia. NACCHO offers a range of resources for local health departments related to tobacco programs and issues. The home for all of our resources is the tobacco page on our website. There you will find links to fact sheets, issue briefs, stories from the field, tools from other organizations, and our new guide, Best Practices for Comprehensive Tobacco Control Programs at the Local Level. In fact, this guide is being released today to coincide with this webinar. NACCHO's guide is a companion to CDC's Best Practices 2014. It briefly summarizes the research and evidence cited in CDC's best practices, and it frames the recommendations as local level strategies that can be implemented in concert with state and federal level activities. NACCHO's guide describes the goals and components of comprehensive tobacco control programs and emphasizes the role for local health departments. The guide lists the recommended practices for each program component, summarizes the evidence-based rationale for the recommendations, and outlines the minimum and recommended funding levels for each component. NACCHO's guide is available online. I can also assist you in obtaining the document or help you with other matters. You are welcome to contact me directly for technical assistance through my email address here, shown here on this slide, and at the end of the webinar.
Great. Thanks so much, Erica. And so we'll wrap up. Here on your screen you see a ton of resources that are offered by ASTO. We offer resources on the perspectives, capacities, challenges, and opportunities to implement state-based tobacco control and prevention initiatives. ASTO also provides national leadership in linking and aligning tobacco control with other chronic disease prevention areas such as coordinated chronic disease, cancer, maternal and child health, heart disease, and stroke prevention through our Million Hearts initiative. ASTO also provides a range of materials and resources on its tobacco page at www.asto.org/programs/prevention/tobacco, which you'll see on the screen now. And so for any assistance that you might need, feel free to contact me or my colleague Joshua Berry with any questions that you have. And then you can also contact the Tobacco Control Network by emailing tcn@asto.org. And so the Tobacco Control Network is a newly recognized ASTO peer group that's comprised of the Tobacco Control Program Managers, additional Tobacco Control Program staff, and then also the territories, and DC is represented as well. This wide representation allows the network to access a wealth of expertise and experiences from across the country. It was formed in 1994. The network's primary function was really to facilitate information sharing, and now it leads efforts with a focus on raising the primary tobacco control and all state and health agencies, as well as fostering collaboration and communication among state programs. And so we invite you to email tcn@asto.org if you would like to be added to the TCN newsletter listserv. And then I would also invite you to check out the newly redesigned Tobacco Control Network website. It actually launched earlier this week on February 4th. So please visit that and let us know what you think. If there are other suggestions that you might have, we would love to hear those things. Something else coming down the pipeline from the Tobacco Control Network is the TCN Policy Guide, and also a summer webinar series that is going to feature topics on disparities, having tough policy conversations with leadership, and then a deep dive into that anticipated policy guide. So I would also like to invite each and every one of you to share any of your local and state-level success stories with ASTO. We would love to put them on our website and share them with other state leaders. As you all know, peer-to-peer learning is very important, and that's definitely something ASTO would like to facilitate. So if you have great work going on in your state related to tobacco prevention and control, please let us know. We'd love to speak with you more about some of the steps and processes and evidence-based strategies you implemented, and work with you in developing a really nice piece to share on the ASTO platform. And finally, before we wrap up, I'll just share one of CDC's best practices guides because it's so closely related to the topic we discussed today. This is not a new guide, but there is a hard copy of this user guide available on the URL that you see on your screen. CDC promoted it last week, and we just wanted to reiterate that since it's so closely aligned with what we were discussing today. And so we encourage you to visit this web link to order your copy of this Best Practices User Guide. And so we have a few minutes left. We have about 15 minutes before we wrap up. And so if there are other questions, we invite you to put those in the chat box. And we're happy to take any additional questions you have. And I'll turn it over to Erica just to see if she has anything further to share before we start taking questions.
This is Erica. I don't have anything further to share, but I'm really excited about the resources that NACCHO and ASTO both have to offer to local and state health departments. I think collectively, working all the way through all levels of public health and government, we have a great opportunity to improve the health of our community and our residents. And I look forward to sharing the resources, speaking with anybody who has any technical assistance questions or is just trying to find something.
Great. Thank you, Erica. We have a question in our chat box asking about the web link. I'm not sure which web link that you're referring, so if you could give us a little bit more description there, we'd be able to respond to that and happy to do so. We are going to be sending out the links for the presentation and the recording. That will go out via email, and then we will also have them on our website. And those URLs will be available at the end of the presentation. And it looks like those were our only two questions asked. So, the CDC web link. Okay, let me go back to that slide. So this is the CDC web link to order the hard copy of the Best Practices User Guide. It's a pretty long one, but again, we are going to share this slide deck with everyone, so you could refer to it at that time once we send this information out, and you can access the link directly from those materials. So without any other questions, we would like to just invite you all to please complete your evaluations immediately following the webinar. We are going, as soon as you close the webinar, it will take you directly to the link to complete the evaluation. It shouldn't take you longer than about 2 minutes, so we really look forward to hearing your feedback and how we could make these learning opportunities better in the future. Special thanks again to Dr. Ellinger and his team that helped him to prepare today. All of the staff in Minnesota, we really appreciate you all joining us. And also special thanks to my colleague Erica at NACCHO for co-hosting the webinar today. This concludes today's webinar. ASTO and NACCHO, we're really delighted to have so many people join us. And so, as we said, the recording of today's webinar are going to be available on the website links that you see on your screen within the next 2 weeks. And then we will also be sending out an email with the link to the recording as well as the presentation materials. So if you have any further questions, please feel free to reach out to the teams at ASTO and NACCHO. Thank you, and enjoy the rest of your day.